Hello and welcome to Bristol Health Cares. I'm your host, Kurt Barwis. I am the president and CEO of Bristol Health. This program is for you. It's really about how you navigate the system of care, how you access care, and it's really about trying to answer questions you may have and really didn't know who to ask. We are going to bring to you professionals, doctors, surgeons, other healthcare professionals throughout our system of care, maybe people that you've never talked to before or met before, but the goal is to really help you understand how to access care when you need it. You're going to enjoy this program. This program is really for you. So what's important is if there is something that you want to learn about or know about or a guest that you'd like me to host on this show, write us and we'll try to make that happen for you. So enjoy the program, Bristol Health Cares. Hello and welcome to this episode of Bristol Health Cares. I am Kurt Barwis, President and CEO of Bristol Health and your host today. And today we have an amazing guest with us, Dr. Margarita Reyes. Dr. Margarita Reyes is, she heads up our geriatric medicine program at Bristol Health. She has unbelievably covered a lot of different areas of focus, palliative care, our hospice program. Dr. Reyes, welcome this morning. It's so great to have you here. Tell us a little bit about yourself.
So, like you said, I specialize in geriatric medicine, but I also practice palliative and hospice medicine.
Yeah. So how about your background? Let's start with the basic stuff. Tell us about your journey to do what you do today, because obviously it's a very long journey that you took.
I grew up in the Philippines, but actually I went to school all around Asia because my father was a diplomat. He was an economist. So I had the privilege of being exposed to different cultures. So I lived in countries like Laos, Thailand, Indonesia, and I did my college at the University of the Philippines and my medical school also in the Philippines. It's called University of Santo Tomas. And even since medical school, people always ask me how I ended up in geriatric medicine. It's interesting because when I was in medical school, we didn't even have the subject of geriatric medicine. So now I'm starting to realize I think I was just brainwashed by my parents so that they could be assured that someone would take care of them because I'm the first physician in the family. And so when I was growing up, I always thought I wanted to be a doctor to help people. I said I wanted to help the poor country of the Philippines, but my dad, who's an economist, said, how are you going to help the Philippines if you have no means of doing it? And when I was doing my fourth year in medical school, I realized that's true. I had to actually buy IV fluids. We had to reuse needles for patients, clean those instruments ourselves because the hospitals and the people were just so poor. And I realized no matter how much you study, it's very difficult to practice in a poor country. And that's why I ended up here. Also because we all know that the United States provides the best training. And so I did my internal medicine at UConn and then geriatric medicine in Boston and Harvard. And then I ended up in Bristol. That was 11 years ago. 12 years ago was when you interviewed me, Kurt. And a lot of people may not understand, but the reason why I ended up in Bristol is because it's also an underserved area in the United States. So I was on what's called a J1 waiver. And I've just been here since.
We have so benefited from your contribution to the community. It's really interesting. I really never talked about, but Bristol does have that designation as a health professional shortage area. The designation is driven by the economics of the community in our particular case. So there's so many aspects to that. It could be a shortage of physicians, just a lot of physician shortage. It could be a variety of factors, but in our case, it's because the economics of the community are not that great. But so wait, I heard you say you actually bought the medications for your patients. I mean, that's incredible.
Yeah, there was even a day I would ask my dad to come to the hospital and bring me my allowance. I needed to get an advance in my allowance because I needed to buy IV fluids for a patient who was having like a pediatric patient with diarrhea.
Oh my God, that's
And
horrible.
yeah, people die from dehydration and diarrhea in the Philippines.
So wait, I got to ask this question. So how much was your allowance?
That's still an issue with my siblings until now because I'm the youngest and they think I'm spoiled. But I think in medical school, I remember I asked him to bring me my month's worth of allowance. I think it was $200 for a
Wow.
month when I was in medical
Great
school.
for a month. I mean, that's $50 a week, and you didn't have to do chores for that. Like I had to do
Oh,
chores for
no,
my
no,
allowance, like the dishes and the laundry and stuff. Anyway, so this practice, the focus on geriatrics, really, you created an amazing center of excellence for Bristol Health and the whole community. It's extraordinary, and it's grown significantly. And I remember in that interview and kind of canvassing the community, there was a difficulty in getting individuals into those programs. It was UConn or Yale had programs and a long waiting list. So it was absolutely a identified need. And so you started out and you were like busy overnight, right? I mean,
No, I was not busy overnight. I mean, the task was, Kurt, just start a geriatric medicine practice, and I came right out of fellowship. But I realized in the end, it was just about responding to the need. So whatever the community was asking for, then I was not saying no to anything. So in the beginning, I was doing home visits. I had no idea actually what it was going to be because you go through training and you go through the different, aspects of geriatric medicine. But when I was asked to just start a practice, whatever the patients needed, then that's what I responded to. And so over the years, it just grew into basically a dementia practice. I was tasked not to do primary care, but to do a geriatric consultative medicine practice. And that was the need. The need was dementia, memory care.
Yeah. It's interesting you say that because I remember the conversation was you're also an internal medicine physician. And so to get other physicians to refer to you, their concern was the patients would fall in love with you, of course, and they would want to move their primary care to you. So I remember having that conversation about restricting to only the geriatric medicine piece of it, which that turned out to be a good thing, I think, overall.
Yes, great
Especially since the
idea.
need is so great. So when you get referred a patient or a patient comes to you, the process is pretty extraordinary, right? I mean, the intake process for a new patient, could you kind of describe that, how that works, the testing, everything that you go through, the family stuff?
So typically, first of all, it's not just the patient. The staff know that I don't require, but I prefer that there's another historian during the visit, a family member, a friend. And my initial visits take an hour. Typically, because there's just so much. First of all, a lot of them have hearing impairment, or a lot of them, for instance, speak another language. So that contributes to the time needed. And then I need to talk to the patient. I need to get history from the family member also. And I have to go through so much, not just about what's going on with their memory. I have to go through how they're functioning day to day. I have to review all of their medications, make sure there's not a single medication that's causing more harm to their overall health, not just their cognition. And then I have to do a cognitive exam and go through not just memory, but different aspects of brain function. And I do a physical exam, a neurologic exam. And then I have to actually talk to them about what my findings are. And a lot of people have actually told me when they hear dementia or Alzheimer's disease, well, at least many years ago, now not so much, right, with all the new treatments, but they used to say, this is the worst news, this is worse than hearing I have cancer. And so, of course, I have to support them through that.
Yeah.
Through hearing that, then come up with a plan and talk to them about the plan and get the buy-in to the plan. That's why it takes such a long time.
Yeah, and having a lot of neighbors that have dementia and Alzheimer's, and being very aware in the community of individuals, there has to be a plan. There has to be a support structure. You've also really focused on communication. Like, you've done great education to the community on how to talk to somebody. And I've actually, because I sat through those classes, I think it also works with difficult conversations as well, not necessarily somebody who's got dementia. So I think, there's so much to it. And I think some people probably don't necessarily get the right referral to somebody like you who's going to help them in the totality of what's going on. But you just laid out this comprehensive kind of picture of the beginning of the process. Now, there's a lot going on in the area of research, new drugs, new tests, and things like that. How do you see the future? I mean, is it going to really get better for these patients?
Definitely, Kurt. When I started 11 years ago, that's how I ended up in palliative care and hospice, right? Because many of the patients that we treat for hospice now, it's not cancer anymore. It's predominantly dementia now, Kurt, because 11 years ago when I started, that's all I could do. I could just help symptoms. It was palliative care, symptom palliation, support of the patient and the family. But in the past, I would say 3 to 5 years, so much has changed. And that's why I feel almost lucky to be in this field and to be a dementia specialist, because I'm coming and joining right at the time when there's just so much going on. There's so much going on with testing. We have blood-based biomarkers now, spinal fluid biomarkers, amyloid PET scans. And then at this present time, there are 2 FDA-approved drugs that actually affect the pathology of Alzheimer's disease. It actually removes amyloid protein from the brain and actually has effects on cognitive decline, functional decline. So very exciting times. And I think the future will just add more and more drugs, more and more tests, and even coverage. Coverage is becoming better and better.
Yeah, I remember when Medicare approved one of the drugs, and all of a sudden, all the Medicare enrollees got a gift of a huge increase in the premium, and then I think they retracted it. But from a layperson's kind of standpoint, when I think about the new testing and then the new drugs, it feels to me like the testing is, at least from what I hear, one of the most important pieces of it, because if you can identify it early, you can utilize those drugs earlier, which would have potentially, whatever that is, that those things that in your brain that cause it, if you could stop them from growing earlier, you could really stave off the ultimate unfortunate decline. I mean, did I say that right?
You said it perfectly. Okay. So the main message now is early diagnosis, early detection. People used to think dementia, Alzheimer's disease are, when you picture a patient, it's those patients in the nursing home. But now, Kurt, you have no idea. It's people you work with. It's people you see and interact with day to day. These are very independent people, and if you catch it early, then you can keep it at bay with the new tests, with the new treatments.
So what is that? So for the average person, and kind of, what does that look like? How could they, because is it the person? Is it self-awareness? Is it more somebody else saying, hey, you're forgetting all this stuff, or, what's going on? You don't seem right. Like, what are those warning signs that people should be aware of?
I would say it's both. Unfortunately, sometimes the disease also affects self-awareness. And so, there's some patients who know that there's something going on. I think the first stigma is, if you think there's a change, do not be afraid. Now is the time to tackle that.
Yeah.
But if you also know someone, whether a friend, a close family member, and something's just different cognitively, even behaviorally, then, bring it up, right? And encourage evaluation, a thorough evaluation, because like I said, it's early diagnosis and the treatments now are only indicated for the earliest stages.
So let's say you're suspicious, you go in for the testing, but it's not a problem, right? You're not in the early stages, but now you have a baseline, right?
You got it.
So a baseline's actually a good thing. So you can't say, well, it was for naught. Like my wife always tells me, you need to get your ears checked. I mean, that's probably a common thing, right? So I went and had a hearing test, no problem, right? Which kind of indicates a different problem, right? But I have a baseline, right? And I think that's what people kind of need to understand. It's if you have a concern, you have a doubt, pick up the phone, talk to your primary, get the referral, come in. It's interesting this morning, one of the things that I notice as I get older and older, I trip all the time and I tend to fall. And so my wife, Jean, is always like, there's something wrong, you're not doing something right, you need to get checked out. And then I read an article this morning in AARP, I wear progressive lenses. And there was a gentleman who was 65. And so I was like thinking, maybe I need to come and have a baseline with you because this is an absolute change in what I'm experiencing at 66. But here, there's this whole new research around progressive glasses that people can't see the bottom step. And I played it through my head and I'm thinking, wow. And so now I'm going to go back and get single lenses. Yeah. But it never was a problem before. And I've always worn progressive lenses. So I think, for myself, I'm constantly, because you really get hurt. Like I got really hurt falling 2 weeks ago. And it's like being aware is important. I didn't realize that having, early stage of dementia and some cognitive decline, you may not be self-aware. So you need to have that feedback loop from that spouse, like I have.
Especially from the spouse. Be open to feedback.
Yeah, you can't shut it down. You gotta listen. You're absolutely right. So now, how does someone kind of enter into your universe of care? How's that process work? We talked a little bit about referrals and things like that, but does it have to be a referral? Can it be a direct call to your
I would say
center?
majority of my patients are self-referral. Some of them see me on TV. That's one.
You are such a personality too.
But others, interestingly, like I said, I've been here more than a decade, right? More and more I'm seeing the children of my previous patients from a decade ago, which is good, Kurt, because then they're coming early, right? They saw their parents go through it and they want to be proactive about figuring things out and doing everything they can to prevent the same outcome as their parents. So no need for a referral. Self-referrals are welcome. But of course, it's always good. And, for me, part of my role is partnering with the primary care physician. So, of course, I always do my best with that.
So you just touched on something that's kind of interesting. So is it genetic? Is a family history one of the things that you should be very aware of?
Yes, family history can be one of the risk factors, but the biggest risk factor is age. It's an aging population.
Oh Thank you for telling
No,
me
if you
that.
look at the graphs, it's the people who are over the age of 70, 80, 85. That's why the population is growing, right? It's that demographic that's growing. That's why I feel secure in what I do in my job, because that population, I forget the number, but I think right now it's about 6 million people in the United States who have Alzheimer's disease, and by 2030, 8 million, and that number just keeps growing.
Yeah, it's getting old is difficult. I mean, so are there, I read a lot about how stimulating your mind, reading, being active, having something, volunteering, a hobby, whatever. Is there truth to that?
Definitely. There's a lot of data to that. Staying active physically, even if it's walking, like you work out, that's excellent. Lifting weights, that's excellent. Staying socially active, we're very good with that also.
Yeah.
That keeps the brain very healthy and mentally active. In particular, learning something new, like a new language. You know, we do the same thing over and over again, but challenging your brain to learn something new is also what's good, even if you're retired. And I would say, a healthy diet would be a
I was going to
Mediterranean
ask that
diet.
question, like blueberries. I always hear blueberries are good for your brain. Is that?
Sure. Blueberries have antioxidants, but in general, just consuming the whole rainbow. A Mediterranean diet, a lot of vegetables,
Yeah.
healthy fats are good, seafood is good, lean protein, avoiding processed foods, avoiding sugar, avoiding carbohydrates that
All
are
the
not
good
very
stuff.
healthy. All the good stuff, yes.
No, so it's just it's an overall healthy kind of approach to your life. And healthy isn't just lifting weights or running or something like that. Yeah, it's what you eat, it's interact, and you said socialization is so important. You know, watching my parents grow old, they everybody engages some different way. To them, it was their church, it was the, you know, the group of people that they socialized with was so important to them, and it supported them. So, I think that's incredible advice. So then, so you, your kind of thought process. I was going for another life insurance policy the other day, and then the interesting thing was, the term was to be 109. Actually, I saw it yesterday, and I was like, I called up my agent. I said, "Wait a minute, 109? Is that possible?" And he said, you know, used to be that those policies went to 95 max, but it's true. Like, people are living so much longer today, and I can only imagine. You know, we're talking about dementia and Alzheimer's. What else is there at, you know, as you start to crest that 100? I mean, is there going to be like new stuff happening, you think?
You know, I think I don't know if I'm excited about 109. That's the other part of what I do, right? Because I see, now it's definitely more hopeful, but I think more than the number and the length that we're living, I think it really has to be the quality of that life that we're living. That's why I think, you know, maybe for another episode, right? Palliative care, it's about goal-directed care. It's about quality of life, however old you are. That's, I think, the next important thing to focus on.
That's a great segue for the next program we're going to do. So any last thoughts for the viewing audience here? Any key takeaways? I mean, we covered a lot of grounds.
No, I think now be proactive. It's about early diagnosis, early detection. It's nothing to be scared about now. In fact, when I see, when I diagnose Alzheimer's disease now, I'm actually thankful that it's Alzheimer's disease rather than some other form of dementia that at this time I cannot do much about yet. So, you know, I think we have to get rid of the stigma of Alzheimer's disease and dementia because, again, there are newer treatments that we could give.
Yeah. Thank you so much. This has been really educational, enlightening, and it's always like exciting to hear the things that you have to say. You're totally at the top of your game on all this. So really appreciate it, and I'm looking forward to having you back again. This is Bristol Health Cares. You can write us at cares@bristolhospital.org. That's cares@bristolhospital.org. We've gotten some emails, and we appreciate that. A lot of feedback. We love that. If you want to hear a different topic, something that I haven't covered, you know, please let me know. I work hard to try to do that. I want to say a special thanks to the production crew here at Nutmeg TV, and also very much plug Nutmeg TV as a nonprofit, community-based organization that needs all of our support to be able to put these kind of programs on a routine basis and cover all the events that are going on in your community that you can actually, if you're not going to go there and see them, you can watch them being replayed on Nutmeg TV. So until the next episode, this is Kurt Barwis, and thank you very much for watching us. You can write us, cares@bristolhospital.org. Take care. Have a wonderful day.